Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Okay, hello everyone, and welcome again to Dementia Care on Air. This is a Dementia Care Aware podcast, as you know, where we go over topics that we've also done in our webinars. You can find the webinars on our website, dementiacareaware.org, and link to our recorded versions on our YouTube channel. And I'm so glad today to have the opportunity to do our part 2 of behavioral symptoms in dementia and how we can work on supporting patients living with dementia, their caregivers, on addressing behavioral modifications and treatments for these really, really common behavioral symptoms. Once again, we are so fortunate to be joined by Michelle Panlilio, who is a nurse practitioner and the national lead dementia care specialist for the UCLA Alzheimer's and Dementia Care Program. And as you probably saw in our webinar in our previous podcast, she's incredibly experienced in dealing with these issues. So we're really lucky. And we already sort of pre-discussed and got ready to really address the most common symptoms. So Michelle, first, I want to welcome you. Welcome.
Thank you so much for having me again. It's a pleasure to be with you.
Wonderful. So let's just jump right in. So we went over the last webinar, sort of what common behaviors are, sort of what we mean when we say behaviors in dementia. And then we talked about sort of how you would identify those behaviors, really frankly, label them or name them properly, and then start to develop an understanding of how severe these symptoms are. And now today, and your prior webinar is really to address like, okay, now what do we do about it? So thinking about your average, primary care team or provider facing a patient, what would you say are the most common behaviors that you're seeing and that you're supporting primary care on?
Well, that's a pretty broad question, but if I had to pick the 3 most common questions that I encounter, both from my partnering physicians as well as the caregivers who are coming into our program, probably the first one would be bathing problems, in that our patients don't like to bathe for one reason or another. And then I think the second one would either have to be agitation or sexual disinhibition, but those 3, I would say, come up the most often.
Okay, so I'm going to point out the obvious, which is I know in my practice, I don't think sexual disinhibition comes up that often. And I think what's so wonderful about having your expertise is that this is actually something that's really, really common, but it's hard for patients. Well, definitely patients and also their care partners and caregivers to bring up. So we are going to get to that one last, but it's just so important, and especially from the perspective of really helping people with the things that are affecting their lives the most and really, really bothersome. But let's go back to the first one. You said refusing to bathe or bathing issues. And what do you sort of mean by that, and how do you approach it?
So it could be as simple as caregivers coming into the clinic and saying, Michelle, I have a hard time with giving my mom a bath. She usually fights me, or she resists me, or she pushes me away. Or it could be that she told me she's already had a shower, and we know full well that that didn't happen. I get comments like, Michelle, my dad hasn't had a shower in 2 months. How am I supposed to convince him to shower when he smells bad and he doesn't acknowledge it? He's wearing the same clothes, and yet he won't let me help him change clothes. That's usually what I will encounter in practice.
So how do you tell people to start to approach that?
Well, So I think the first approach that I do is I'll ask them, what are your expectations? And if the family's expectation is, I want him to shower every day, then it usually starts there, like, which is a lot of caregiver education and letting them know that, you know what, it's probably not necessary for mom or dad to be showering every day because they are older. Their skin is actually thinner and a lot drier. So having dad have a shower or a bath maybe once or twice a week is actually okay. And once a day, once every day would be too much. And then I would ask the caregivers, can you define or what are your expectations with bathing? Well, if their expectations is for mom or dad to have a full bath, like in the shower, hot shower, scrubbing their hair with shampoo and conditioner and putting, cleaning their body off and then putting on lotion, if that whole routine is what they are expecting, then I will discuss options of bathing with the family. So again, kind of going back that our patients don't need as much scrubbing or shampooing or conditioning as they normally did when they were in their 30s or their 40s. Then we talk about different types of bathing. So we talk about options like a sponge bath. What is a sponge bath? Is it appropriate? If we talk about other methods of bathing, so it could be a shower, it could be a tub, it could be a sponge bath by the sink, facing the sink, and with varying levels of assistance. Meaning, are they doing it for mom completely, or are they just on standby, kind of making sure that mom or dad is doing it properly on their own? The other way that we can recommend too, we have some patients who are willing to do a sponge bath, but maybe they just will not allow people to touch their hair. So sometimes we do have some patients who still enjoy going to the salon. So if going to the salon once a week or once every 2 weeks just for a shampoo is what is working for mom and dad, then that's something that they can try. That's an option. But kind of long story short, it does not have to be a full bathing in the shower, kind of an ordeal for each and every single patient all the time. There are alterations to it.
Okay, this has already helped me so much. I think I've been skipping the expectations part, and so really kind of understanding where they're coming from and where they expect this person to be, how far off they are and how reasonable their expectations are. And then figuring out different strategies to get some, hygiene routine in there for, so there are different solutions to different issues, which could be different for getting hair done versus just sponge bath. Or I've even seen people just basically use like wipes, like the kind, that you'd use for a child or something like that.
And I just wanted to add to that with bathing, it's usually it's hard for families to change because it's probably something that has been going on for a long time before they even mention it to you in your primary care office. And so not only are the patients going to have to change, but the caregivers are going to have to change their approach. So they might not always be willing and open to trying out your recommendations the first time around. So usually if I know that this is a problem with a patient, during our follow-up appointments, I'll continue to follow up with them. And I'll ask, hey, you brought this up the last time. How's that going? Did you try any interventions? Did it work? Or what worked and what didn't? Because if something didn't, then maybe we can try something else. So just keep on revisiting the situation.
Yeah, always that's always key to like sort of follow up on how our recommendations did. And then okay, it's just I'm of course flashing back to so many different patients. So I remember one patient who for some reason her daughter thought, and it worked out, that if I just got on the speakerphone and said, for XYZ health reason, you really need to just bathe at least today, and maybe, we'll try again in a week. And that worked at least that day. I couldn't do that every day. Another patient, I remember it worked if the family sort of mentioned that it was like, oh, we're all doing a spa day, and everybody got robes and did they put some nice scented bath bombs out and that sort of thing. And then I remember one guy who just didn't shower for years, and he just sort of did a little bit of a sponge bath with some wipes. And frankly, he looked very well and never smelled, and was totally functional. So I really and accepting that there may be a diversity of options and and sort of outcomes.
And it's something that you can also talk to families about, because with my patients, especially my patients who have known their primary care doctor for a long time, so they can always use fiblets in that, telling mom or dad that, hey, listen, tomorrow you have an appointment with Dr. Chodos, who you love. So you have to make sure that you shower so that you're clean. Or it could be that you are trying to motivate them to something that they like. Let's say that they like to go out to dinner. So maybe, maybe strike a deal. If you shower tonight, then I promise I'm going to take you out to your favorite pasta place. But you got to do it. So it could be something as little as that. And they just, pull that card, the pasta card, maybe once a week.
And just out of curiosity, do you get questions about like the health implications of not bathing? So for example, I often say, actually it's usually basically fine if we mostly don't bathe, but sometimes with ongoing like incontinence issues, there's some concern there. And that's definitely a fair point. So I say, really try to focus on encouraging them to sponge bathe or whatever it is, just to stay clean and hygienic around toileting. But I'm just curious to know if you have a standard answer for that question.
It does. I mean, to an extent, right? Aside from not feeling comfortable if they're oily or if they're unclean. Usually I will say something like, yeah, we worry about, you developing urinary tract infections or some kind of a rash. If it gets really bad, you could get really sick. And I try to make it somewhat of like an ambiguous, you might get sick. You might get sick if you're not clean or taking care of yourself. Then that's usually good enough. I don't want to scare them too much. But yeah, usually the caregivers are already concerned about that anyway. So me just kind of echoing what the family has already said is usually helpful.
Wow, awesome. This was a great coverage of this issue and how we can kind of approach it. I'll say also to throw it in, I often recommend videos from your program, from the Alzheimer's and Dementia Care and UCLA Health Geriatrics videos. Just that's also helped a lot of people. So just want to put a plug in for that.
Thank you. It's available several different languages.
Oh yes, fabulous.
Yeah.
So important. Yeah, especially here in California. Okay, so then the other one you mentioned was this sort of, I would call it like a bit of a bucket, called, agitation. So different symptoms that are kind of more, have an aggressive element or a sort of irritability element. But how are you typically assessing that symptom, and what are you starting to work with people on?
That's a great question. I mean, you're right. It is such a big bucket. How we normally find out about the presence of agitation in the home setting is because when we do our initial and our annual appointments, so once a year, we have, as I mentioned in the webinar, we do the neuropsychiatric inventory questionnaire, and it asks, does your loved one have any agitation or aggression? And so that's how it comes to our attention that the patient is having this at home. But, to your point, it's really interesting because caregivers, they can have varying levels of what they describe as agitation, right? Agitation could be something as mild as, hey, honey, stop telling me what to do. You're not the boss of me. Or, them telling their caregivers, I don't like seeing you here. I don't like having you here. Get out of my house. It can be something as mild as that, all the way up to, physical agitation and aggression that somebody is getting hurt, right? So hitting, kicking, pinching, punching. But there's so many different levels of agitation. So if and when we do encounter it in the clinic, I will explore what the family is talking about, and I'll ask them, agitation, kind of like how we're talking about it right now. Agitation is such a broad term. In your own words, can you tell me what is happening at home? Why do you think your mom is agitated? And how does that impact you as a caregiver?
Okay. And so now they're saying, yeah, they're every time I have to go out, I have to do errands. They're totally refusing. They get really upset. They're yelling at me. Um, I guess take us through some examples and what concretely is some of the advice that you're giving.
Let's see. I can think of one. So something that happens a lot is agitation during hygiene care. So kind of back to bathing, right? So this is a time when if you have a patient who is in the advanced stages of the disease and you have a caregiver, whether it's a paid caregiver or an unpaid caregiver like a family member, this is a time when the caregiver is in very close proximity to them. It's usually a time when they are vulnerable because they are often naked and their genitalia may be exposed. Maybe they're in the shower and they're cold. And so a lot of our patients don't like it for that reason. So then how do they respond? The patient might, hit or yell or punch or throw something at the caregiver. And there are so many different approaches to that kind of behavior. The first one, you always have to assess for safety, the patient and the caregiver safety. If it is a patient who is, a bit frail and not able to hurt the caregiver too much, it's not so much of a concern versus if you are taking care of somebody who is who has been diagnosed with early onset, who's maybe in their 50s or 60s, and they're able to inflict a lot of injury on their caregiver. It's two very different stories, right? For let's say that we have an 85-year-old patient with Alzheimer's disease and they are aggressive towards her caregivers. What we would normally do is we would have the caregivers give them space. First of all, they need to let them know what they're doing. So instead of just like taking their clothes off or scrubbing their body, we will have the caregiver say, hey, Mr. Smith, I'm going to take off your gown now because it's time for your bath. And then do it one direction at a time, one explanation at a time. And you do this before you're going to do it. If the patient is able to do it for themselves, then give them step-by-step instructions on what they need to do. Meaning, take the sponge and scrub your chest with it. It could be something as simple as that. And then that way they have some kind of a control in what they're doing and that they are a part of the process and that it's not just being done for them, because that can be a trigger in itself, that they don't like other people doing things for them, particularly if it's involving their hygiene care. Now, let's go to the other end, the other end of aggression, which is, let's say they are very aggressive. If they are very aggressive and they are striking out at their caregivers, but yet we know that for sure the hygiene care has to be done. So let's say changing diapers, right? There are some times where we will start talking about medications, and that might be the time when it is appropriate because that type of hygiene care has to be done. And if the caregivers are just not able to do that without getting a black eye, then we need to start talking about medications. So medications in addition to the behavioral modifications that we're doing, such as leaving them alone, such as giving them step-by-step instructions, such as allowing the patient to participate in their own care. And I think this goes for all of the behavioral problems across the board, right? If the caregiver or the patient safety is being compromised, then perhaps it might be an appropriate time to start talking about pharmaceutical treatment.
Great, amazing. Because, yeah, I think we're pretty clear in all of our teaching, across geriatrics, is definitely that, when it comes to behavioral symptoms of dementia, very often, they're amenable or at least manageable to these behavioral interventions, meaning that people around them are changing their behaviors and, and able to interact differently in a way that doesn't, exacerbate the issue. And perhaps even completely get rid of the issue. And I think the other piece of this, which isn't as explicit, but you bring up, is that you're managing expectations of everybody, that it may not be who they were or how they were behaving before ever, but it may be something that's less bothersome to you. Okay, so first, we're always trying all these different behavioral interventions. We're doing trial and error. We're checking in and saying, what worked, what didn't. Okay, let's change tack. And then if it's really unmanageable, we might think, okay, a medication could help. And I think we do have to address it. Do you have a quick spiel you usually give patients and other doctors, I guess, or clinicians that you're working with who might be prescribers on what medications you might consider? And I'll just out of the gate say something like bathing. I don't usually think I'm going to medicate this issue away. But something like, really intense aggression, physical violence, yelling, very severe irritability, I might think, okay, a medication might help take the edge off and kind of make this situation more manageable and frankly more safe for everybody. So I'm going to turn it to you and see how you usually coach healthcare teams and patients on this.
So those are great questions. And again, I think it depends on the severity of the behavior. So if we have somebody who is maybe irritable or agitated only when it is surrounding bathing, kind of like sticking to the topic of bathing, meaning we have an identified trigger, like we know it's bathing and that is the only isolated time that she's having aggressive behaviors, then I might push the caregivers more with other behavioral modifications. It is when the caregiver's safety is being compromised. That's usually when I will again look at maybe it's more appropriate right now to start the patient on medications. As far as the type of medications, it depends. So if it is something that is isolated, let's say to bathing, right? Then I'll talk to families. How bothersome is this really for you that they're not taking a full bath? Well, it's mildly bothersome. Okay. Well, I see that we have explored a lot of behavioral modifications. You've had some success and maybe some not so successful attempts. How do you feel about adding a medication only for that particular time during bathing? Let's say we're only going to do it once a week. And I have done this in the past where I make it a PRN. So it could be that maybe we do a low dose trazodone an hour before bathing. Or maybe we try low dose Seroquel, so 12.5 milligrams PO, QD, PRN bathing. Understanding that, hey, this the only time that you're going to go and give mom the Seroquel or the trazodone is once or twice a week right before bathing. And then kind of see how they respond and really try to work with the family on what is an acceptable course of treatment for them.
Great. And so I'm going to call out a couple of things that you mentioned. So we're often using medications that essentially have a sedating effect of some sort and a calming effect that aren't benzos, because benzos have these paradoxical reactions in a lot of people with dementia where they get much worse or get totally delirious or fall. So, we might be trying, and I actually hadn't really done that. I haven't really done that, but, low dose trazodone or a very low dose. We start the lowest doses of some of the atypical antipsychotics. And I know what I've seen most commonly used is something like Seroquel, which you mentioned, or aripiprazole, for example. So, and again, we always start with the lowest dose to see if it has the intended effect, so we're not exposing someone to an unnecessary harm. I think the other principle that I've seen with the medications is if it's a consistent and persistent or unpredictable behavior, it would probably be scheduled, and then we check in and see if there was the intended benefit. If it's, as you say, this really isolated thing, and we're trying to get someone through something basically so that they can have a healthier life and a higher quality of life, then we're going to use it PRN around that time and kind of use it as an adjunct or something. You might think of it that way. So that's really, really, really helpful. I would say the other thing I see a lot used are actually just the dementia meds themselves, to see if that gives that person a little bit of more cognitive support around their behavior. And then sometimes low dose SSRIs, citalopram, to sort of, thinking that some of these behaviors are manifestations of some underlying depression or anxiety, or simply those symptoms. So, okay, that was a good opportunity for me to spout off on all the medications. And I want to get, as our last topic, to the issue that you bring up, which again is so insightful, because this is what you're doing all day and you're seeing this again and again, and people are really coming to you as like their trusted person on dementia care. And the fact that so many people bring up to you, and as we were talking before this recording, really in private and with a lot of, like a lot of shame or embarrassment, they come to you about the issues around sexual dysfunction. So I think it'd be so helpful if you could just walk us through a little bit what that looks like when that comes up.
Yeah, I mean, so as far as sexual disinhibition, we see it often enough in our practice because we are asking about these behaviors specifically during our visits. And with the relationship that I have as a dementia care specialist with the relationship that I have with the caregivers and the families of our patients is very unique in that we will follow them to the point that they establish care with our program, but we also follow them throughout the course of the disease. And so, if we're lucky, we get to see mom or dad when they're in the early stages and they're not having any disinhibited behaviors, but over time, we see that. And so, again, the relationship that we have is unique. So they are usually very open to telling us about these problems at home. However, when it comes specifically to sexually disinhibited behaviors, I think what I do want to bring up is for, any of the providers or clinicians who are hearing this conversation, if this is coming up, if the caregivers are bringing this up to your attention, please be mindful that this probably has been going on for a long time and that it has taken the family a lot to bring it up to your attention because, Dr. Chodos, like you said, this is a very difficult situation and a challenging topic to bring up. There are also a lot of cultural considerations that we need to be mindful to, because this might not be, sexual relations outside of the bedroom might not be an acceptable topic to discuss with your loved one's medical team or even within your family. So again, just be mindful that if this is coming to your attention, it's probably been going on for a long time and likely more severe than what the family is letting on.
And can you give some examples? And by the way, I think earlier I said sexual dysfunction and I meant disinhibition. I'm not sure. Whoops. But okay. So yeah, can you give some examples of?
So some examples that I have seen that are common is that families or paid caregivers are coming in because mom or dad is touching themselves inappropriately. So maybe public masturbation, or maybe exposing themselves in public, exposing their genitalia. It could be that they are touching their caregivers inappropriately. It could be that. On the more severe and more aggressive perspective, I've also seen patients in the advanced stages will commit assault to their caregivers that are sexually aggressive. And, there's varying levels of that. But if it's something that we don't address, it could potentially escalate to that level of aggression.
You mean like sexual assault, like a sort of aggressive,
Correct.
unwanted, contact.
Correct.
Okay. And and so then how do you walk people through options for managing that?
So it depends on their role in the patient's life. So if it's a caregiver, so let's say that it is a paid caregiver, somebody that they hire, and let's say that mom is being handsy or grabby with the male caregiver, then what I would recommend is to hire a female caregiver, and that usually nips it in the bud. Now, for patients who are physically aggressive and they are able to commit sexual assault, then the intervention might be a little bit more different, a lot different. So for those types of patients, if I feel like the family and the caregivers feel that they're in danger, their safety is in danger, then I will probably start that patient on an SSRI or some kind of other medication. I usually like, my personal preference, I like sertraline, because you're able to increase it to a pretty high dose and slowly titrate it. I also like citalopram. I like Lexapro, those types of medications. And generally, they do work well. But my experience, if it involves physical aggression, you do have to go pretty high on the dose.
And then are there, like, how do you counsel people about safety? Like you have a spouse or a partner that, lives with that person, doesn't really have an out.
That is a very good question. So I once had a patient who was sexually assaulting his caregiver, his spouse at the time. And the first thing that I remembered thinking was like, my God, how awful for this family member. And, thank you for letting me know. I wondered how long this had been going on. And I wondered what it took for her to, to tell me what was going on at home. And what I ended up doing for that particular patient is, first of all, I told the wife, I said, listen, this is actually an emergent situation. If this happens again, please call 911, because we are in danger. You're obviously in danger. And the family at that point they didn't know. The wife really didn't know. She thought that this was a part of a disease and something that she had to live with. And so she never thought that it was a medical emergency. So I think, and I may have mentioned this before during the second webinar, is that if the families are telling you that the patient is potentially assaulting them, it's so meaningful to come from their primary care physician to say, this is not okay. This cannot go on. We need to intervene. And so if this happens again, please call 911. This is an emergency. And then call my office. Okay. It's important to give families options for treatment, because one, they may not know there is treatment. And two, they don't know what that treatment is. So with that particular family that I dealt with, they didn't know that medications were an option. They automatically assumed, the wife automatically assumed that the patient, her husband, was going to be sent to jail, which is something that she was not willing to do despite what he was doing with her. So it is very powerful for clinicians or PCPs or geriatricians to kind of verbalize those words to the family, like, this is not okay, I can help you.
I was going to say that, something similar, that I would think we'd really want to get an emergency plan in place, consider if, maybe like if you're in clinic, like even if something has to be done right then and there, like other family or, people need to be involved, and find a way to explain that to the other family that, like, this person doesn't or can't be left alone. People like Adult Protective Services or, behavioral health emergency teams, and every clinic or every hospital is going to be different. But I think, yeah, if you're just in a community, thinking of it like an emergency, like we may have to admit him to, like, or her, to stabilize this and figure out how we're going to deal with it, because it's not really acceptable that you're living in a situation where, you're threatened with assault. And one thing that I'm sort of reluctant to bring up, and I only bring it up as a sort of a conversation piece, and not really as something that I think we can solve, but I would even say I would worry about, specifically law enforcement involvement and wanting to keep it highly, frankly, medicalized, just because someone with dementia is probably, if we sort of criminalize the situation, even though they may have committed a crime, it may get very complicated in a way that is not really, we know our system isn't overly set up to deal with people with dementia. So not to say that we should be ignoring crimes, nor should we be not seeking, justice for the people who are not safe, but like that we have a medical emergency plan for these sorts of things. And it may involve a psychiatric admission, a medical admission, experts getting involved, but that there is something to be done. And I just really thank you for bringing up this particular symptom, because I think we're probably just not asking about it enough, and not asking about it in a way where we can really normalize it. Like, this is a really common symptom. Is that something you're noticing? Any inappropriate sexual behavior, either, because of the setting it's in, or with you, in particular, or whatever. So I really appreciate you bringing it up. And I happen to know you guys have a video about it as well, so that people should really check it out. And we'll put in the show notes a link to your guys' videos, because I know for me, they've been so helpful.
Yeah,
I know we have to wrap it up, unfortunately, but thank you for reviewing these topics and how we would think about starting a care plan. I know we'll have a lot more content on this coming out, just to help people manage behaviors. But thank you so much, Michelle. Your expertise and your experience are always so incredible to have. So thank you so much.
Thank you so much for having me.
Thank you for listening, and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia CareWare team. If you want to learn more, please visit our website, dementiacareware.org.